Well, my presentation is really an educational talk. So I'm not presenting original work. I'm doing. I'm going to provide an overview of the current standard of care for pancreatic NETs. So I will review the evidence from my main randomized Phase II and Phase III trials in pancreatic NETs. And I will then comment on two very recently presented face-to-face comparisons. These are the phase trials that compared head-to-head different treatment strategies and that are going to help optimize the treatment sequence in pancreatic NETs. The first study is the SEQTOR trial. It's a randomized study that compares two different sequences in pancreatic NETs with advanced disease. This is G1, G2 NETs that have progressed and on first and second line therapy. They randomized to receive Everolimus first, and upon progression, chemotherapy with a streptozocin and 5-FU, or the reverse sequence. So with streptozocin and 5-FU first, and Everolimus upon disease progression. This trial has been it was redesigned due to slow accrual. The first endpoint was PFS. The original endpoint was PFS2. So the PFS progression after the 2 lines of therapy, compare the 2 sequences. And it was redesigned to decrease the sample size to 140 patients and to be the first endpoint progression-free survival to first line. And in this regard, the preliminary results were presented at last ESMO in 2022 in Paris. And what they show essentially is that chemotherapy is associated with a significantly increase in objective response rate versus Everolimus, but does not change progression-free survival. So in terms of the primary endpoint, there were no significant differences among the 2 study arms. You may favor chemotherapy if tumor shrinkage is important for your patient, but if not, either sequence could be equally effective. And well, we need more details. We need efficacy by grade, by line of therapy. We need to know also what happens second line, what is the PFS2 and other secondary endpoints, and some translational studies that are ongoing that can help understand better who benefits from what sequence. But at present, there doesn't seem to be major differences. The other the other important study that I am discussing in this presentation is the OCLURANDOM study. That is both were investigator-initiated trials, because this is very often happening in this rare disease in neuroendocrine tumors. And this trial was conducted in France. The first one was conducted was run out by the Spanish group GETNE. The OCLURANDOM is a French study that also is a small phase 2 randomized study comparing lu-DOTA-TATE versus Sunitinib. These are previously treated patients up to 1 prior line of chemotherapy. In general, were heavily pretreated mostly. And what they show is that progression-free survival with lutetium is 20 months. These are the first prospective data with lu-DOTA-TATE in pancreatic NETs, because so far we had just data from retrospective studies or from big series from referral centers, but not within a clinical trial. These are the first data, prospective data. This is important. It's not a sign, it doesn't have a big enough size to demonstrate superiority. That was not the endpoint, but it demonstrates that it's effective and it's a good option. And the PFS in the Sunitinib was about half. So also they provide some safety information. It seems safe, and it will also help us understand better what's the optimal sequence of the treatment strategies, and may probably induce physicians to use PRRT at earlier lines of therapy, because at present ESMO guidelines, what they recommend for pancreatic NETs is to consider PRRT just when they have failed chemotherapy and targeted therapy like Sunitinib or Everolimus. This was based not because it was less effective, but because the quality of evidence was worse. And so I think this is an important study that, together with other ongoing trials, the COMPETE trial, the COMPOSE trial, the NET2 trial, will help us understand better what is the right sequencing of radioligand therapy in pancreatic NETs. Then I discuss a little bit all the factors that are important for the decision in patients, which is, of course, treatment benefit and risks. I discuss a little bit of the risk about all these treatment strategies, safety issues, impact on quality of life. Also, treatment features, patient features, comorbidities, and so on. And, of course, availability, convenience, complexity, expertise of the team, and reimbursement issues, which also influence our treatment decisions, unfortunately.